as, as you can see that our shoulder, the muscle groups, first just for your information, then that whenever patient comes, most common ailment which for which patient comes to us is rotator cuff tendinopathy. So where actually lies the rotator cuff, which muscle we call them as rotator cuff. So this is the front side of the shoulder. So from here if we see, then this is the deltoid muscle. So this is most superficial muscle. Okay, so this is deltoid muscle. If we remove this muscle, then we will see some other muscles. Okay, so what are those muscles? This is supraspinatus, this is infraspinatus, and this is teres minor. And this is from the front side, this is subscapularis. So remember, these four muscles together are called rotator cuff. Okay, supraspinatus, infraspinatus, teres minor, and subscapularis. These four muscles together is called supraspinatus. And remember, these muscles are second layer of muscle. First layer of muscle was deltoid. Now I will start with this knowledge. We will start the PPT part. Okay, so here first, when a patient comes to us, first make a diagnosis. So we in this module we should learn anatomy, then we will go to sonoanatomy, then pathology under USG, what pathologies are important for us, then interventions which are applicable. So in anatomy overview, so as we want to know from where the pain is coming, the main pain generator. So what can be the pain generator? The structures which are there. So what are the structures? Bone and joints. Most deep structures are bone and joints. Then come ligament, tendon, muscle, nerve, blood vessel, bursa. So these things, even the this blood vessel also, I mean, is important while doing ultrasound of shoulder. So here we know which bones are involved here. So this is the clavicle, this is scapula, and this is humerus. Everyone knows that. So these three bones, these three bones are actually involved in when we say that it is a shoulder joint. Actual shoulder joint is glenohumeral joint. When we are talking a shoulder joint pathology, in a patient, say we are saying that shoulder joint is having some problem, arthritis or something, then we mean actually the glenohumeral joint. But there are some associated joint which are also considered part of shoulder joint. Why? Because whenever this glenohumeral joint moves, then it has effect on some other joints also, and they affect the movement of those joints also. So what are those joints? Here it is the actual shoulder joint, that is glenohumeral joint. Related joint is acromioclavicular joint, and another joint is scapulothoracic joint. You can see this X-ray, that scapula in front there will be thoracic cage. So this is a pseudo joint, but scapulothoracic joint is also affected during the shoulder movement. And glenohumeral joint, you understood, this is acromioclavicular joint. Another joint is sternoclavicular joint. So this sternoclavicular joint is also moved while we make a move with the glenohumeral joint. But for ultrasound purpose, we will see the glenohumeral joint mainly, and of course acromioclavicular joint also, because we will go with the clinical presentation of shoulder pain, which is at the location of the shoulder from outside. So here another structure is deepest structure, that is labrum. So labrum is nothing but a fibrocartilage. Here this glenoid portion is shallow, and there is every chance that I mean the head of humerus can slip during movement. It would have been that that situation if the glenoid labrum would not have been there, but glenoid labrum is there. So glenoid labrum makes it a more deep area where the glenoid where the humeral head can stay in a stable way. Okay, so these are the deep structures, and then comes the capsule. So you can see in this picture that capsule, it not only surrounds the glenohumeral joint, but it has some extensions. So these extensions we can call them as recess. Later we will say that we will show that where are the recesses, but you can see one extension of the capsule is around the long head of biceps, also biceps tendon. This is a biceps tendon, long head of biceps tendon, but then the capsule is there also around the tendon. So you can understand, if there is a fluid accumulation inside this synovial sac, some fluid can be seen around the biceps tendon also. Okay, and okay, that we will talk later. Okay, then comes, already I have told what is the rotator cuff muscles. So subscapularis muscle, supraspinatus muscle, infraspinatus muscle, and teres minor muscle. Here one thing is important for you to note. Okay, next muscle I just tell you. So okay, so these are rotator cuff, actual rotator cuff muscles. Okay, these four muscles are rotator cuff muscles. Okay, but these are second layer, second group of muscle. I mean, I'm talking that it is deeper muscles, second group. So what are the most superficial muscles? So one superficial muscle is deltoid. So this is the deltoid muscle. One thing you have to note here, that deltoid, it is in one side, in the front side, it starts from the clavicle. Okay, lateral third, but it is starting from the clavicle. And another side, in posterior side, it is starting from the scapular scapular spine. So there has to be a space in between, between the scapular spine and the clavicle. So what is that muscle? So you can see this muscle is nothing but trapezius muscle, which covers the, here you can see this, from this part deltoid starts, from front side also your clavicle deltoid starts, but in between them the muscle which is present, that is trapezius. So you understand that most superficial muscle above the rotator cuff muscle is trapezius and deltoid. Below trapezius and deltoid, we will see other muscles like supraspinatus, infraspinatus, and teres minor, subscapularis, all these muscles. Okay, so here let's see, uh, here some other associated muscle while we are doing the ultrasound of shoulder. So another associated muscle is your biceps tendon. Muscle has two heads. One is long head, one is short head. So you can see this tendon, which is the long head of biceps. So this tendon is going and joining at the glenoidal labrum. And through which it is going to the glenoidal labrum? It is going through the bicipital groove. Okay, long head of biceps going through the bicipital groove and joining in the glenoid labrum. Short head of biceps, on the other hand, it is going and joining in the tip of the coracoid process. Okay, tip of the coracoid process. So just remember what are the associated muscles and what are the main rotator cuff muscles. Okay, then comes another few muscles which are associated muscles, and we see while doing the ultrasound of shoulder. So what are those muscles? One is coracobrachialis. Coracobrachialis muscle also comes and enters and inserts in the coracoid process. Okay, it is so one muscle we have already understood, that is short head of biceps comes to coracoid. Another is coracobrachialis, which comes to join or insert in the coracoid process. Okay, other two muscles in just associated with shoulder is pectoralis muscle. So one is pectoralis major and one is pectoralis minor. Pectoralis minor also comes and goes above the coracoid process. Earlier it was thought that it inserts in the coracoid process, but actually it goes above the coracoid process. So that is the pectoralis minor. And pectoralis major, where it inserts, it is in the upper shaft of the humerus. So while doing the ultrasound of this area, we see the tendon of trapezius also. Another associated muscle is teres major muscle. So you understand that when we are talking about the muscles, the most superficial muscle between the clavicle and spinous process of spine of scapula, the most superficial muscle will be trapezius, and after that second layer of muscle will be supraspinatus. Whereas in this lateral side, in these areas, lateral side, so there will be the most superficial muscle will be the deltoid muscle, and after that other muscles like infraspinatus, teres minor, these are there. From the front side, in some part it is the subscapularis we will see. So this supraspinatus, infraspinatus, teres minor, subscapularis is the main rotator cuff muscles, and related muscles we have already talked about deltoid and trapezius. Other is this one biceps muscle, and then comes teres major, coracobrachialis, pectoralis. Okay, so all these muscles if we consider, then there are three nerves which supplies these muscles. So most important is suprascapular nerve. Suprascapular nerve supplies two muscles, supraspinatus and infraspinatus. Axillary nerve, it also supplies two muscles, one is deltoid and one is teres minor. Okay, next is your subscapular nerve. Subscapular nerve, as the name says, subscapular is it supplies, and another muscle it supplies is your teres major, which is not that important here. Okay, now we will talk about the ligaments. Now here some ligaments are there, like superior glenohumeral ligament, middle glenohumeral ligament, and anterior band of glenohumeral ligament. So where is the glenohumeral ligament? Which is the glenohumeral ligament? Just a minute. Okay, so glenohumeral ligament, remember here the capsule, already we talked about the capsule which inserts in the glenoid labrum. So part of the capsule becomes thickened and they become the ligament. Okay, so we can see here. So think that these humeral head was attached to the glenoid cavity, and we have just separated it. We are seeing from lateral side this one. Then you can understand that these blue, green, red, these are the origin insertion of glenohumeral ligament. So these are from just above the bone, from glenoid cavity to humerus. From glenoid bone to humerus, this is the location of the glenohumeral ligament. Okay, whereas coracohumeral ligament comes from the coracoid and joins in these part of your humerus. One is greater tuberosity, and this side is greater tuberosity, and this is the lesser tuberosity. So in both the tubercles it comes, this coracohumeral ligament comes and joins. Try to not only the name, we should not memorize the name here. You try to imagine the three-dimensional position. So I am coming from very deep to superficial part. Now, so though I have talked about the muscles, but then after the joints, it is the capsule, and the thickening of the capsule is nothing but the glenohumeral ligament. So it is most deep below the muscle group, and coracohumeral ligament is not thickening of the muscle, but still it is also below the muscle group. Okay, now there are some other ligaments are there. So these ligaments are a bit superficial. So what are those ligaments? Here you can see acromioclavicular ligament. So here from each bone, from one bone to another bone, there are some ligaments. Coracoacromial ligament, from coracoid process to acromion. So this is one important ligament, coracoacromial ligament, from coracoid process to acromion bone. Acromioclavicular ligament, we will see while we see the AC joint, acromioclavicular joint. In those areas, acromioclavicular ligament is small ligament we can see. And then comes your coracoclavicular ligament. From here, the front side, coracoid process small two ligaments are there. One is called conoid and one is trapezoid. So these two ligaments are also seen. But then most important ligaments in shoulder is coracohumeral ligament and glenohumeral ligament, as I have shown you in this picture. Okay, coracoacromial ligament also you can say is somewhat important. Otherwise, acromioclavicular and coracoclavicular are not important. Here, again you see the picture to understand the concept that from where to where we should find these ligaments. So coracohumeral ligament, you can see from coracoid process to humerus. Okay, this yellow line. Coracoacromial ligament from coracoid process to acromion. Coracoclavicular is like that only. So if we put a probe, in a short axis manner in this side, okay, this area, then we can see the coracohumeral ligament, part of coracohumeral ligament on the lesser tuberosity and also on the greater tuberosity. Okay, so this will be important later. Now comes some bursa. Okay, SASD bursa means subacromial subdeltoid bursa, but this bursa is most important bursa. Now, why the name is subacromial and subdeltoid bursa? As I told you that in this area where it is the lateral side of the shoulder, in this area the most superficial muscle is deltoid muscle. Second layer of muscle is supraspinatus muscle. So between these two muscles there is a bursa, and this bursa is called subdeltoid subacromial bursa, because the bursa is not only between deltoid and supraspinatus, it is between the acromion and supraspinatus also. So that's why the name is subacromial subdeltoid bursa. But there is another bursa. So this one is subacromial subdeltoid bursa. This bursa. Okay, this is the same bursa. One bursa. Then comes subcoracoid bursa. So this bursa is under the coracoid, just under the coracoid bone. Okay, but here, okay, I will show a bit later. So this is the subcoracoid bursa. Coracoclavicular bursa is not that important, just under the coracoclavicular bone there can be coracoclavicular bursa. One is supraacromial bursa, just above the supraacromion there can be supraacromial bursa. So here the main two bursas which are important, one is SASD, means subacromial subdeltoid bursa for bursitis purpose, because we are ultimately dealing the patients clinically, and another is subcoracoid bursa. Here see one thing, this picture you are seeing the picture in from a sagittal section from one side. Just think in that way that I just write it. So think this is anterior side. This is anterior side. This is posterior side. This is superior. So we are seeing a sagittal view from one side. Now, and at the level of glenoid, just at the glenoid bone, at the level of glenoid bone we are seeing. So you can understand that we have removed the humerus. So from here. So what we are seeing here, as I told you, that we have one bursa is there, that is subcoracoid bursa under the coracoid process. So here you can see under the coracoid process, this blue is the subcoracoid bursa. But under the subcoracoid bursa there is one muscle, that is the subscapularis muscle. So you can understand this subcoracoid bursa is above subscapularis, not below subscapularis. So this is very important, later we will understand. Okay, so subscapularis, this is above subscapularis, that is one bursa, that is called subcoracoid bursa. Now sometimes we can see fluid accumulating below subscapularis. So what is that? That is nothing but the recess of the joint, recess of the glenohumeral joint. So in some books it is also said that this is also a bursa, but this is actually a subscapular recess. Okay, and these recess can be found sometimes here also under the infraspinatus. So remember, one is recess, one is bursa. Recess is below subscapularis, just above the joint and it is continuous with the joint, and above subscapularis it is the subcoracoid bursa, which is not continuous with the joint. Now, as I told you, coracoid attachment. So three attachments are there. We can clearly see that this has to be the pectoralis minor. This has to be the pectoralis minor, and one is so two is remaining. One is coracobrachialis, one is short head. We know short head is at the tip, so this has to be the short head of biceps. So this has come to the tip. So another, this one is the coracobrachialis. This is known as the coracobrachialis muscle. So though the pectoralis minor doesn't attach here, it goes like this. Okay, but these three tendons are related to the coracoid attachment area. Okay, so one more important thing is coracoacromial arch. Remember, so we have already understood the picture that okay, well, let us see from this picture. So so we have understood that this is coracoid. Okay, this is coracoid, and this part is acromion, this part is clavicle. Okay, one muscle, it is coming from just below the acromion, and that is called supraspinatus, and it comes and joins in the greater tuberosity. So there is a small gap, this gap is very important. Okay, so when they move this muscle, when they pass between this gap, so this gap has to be adequate for the passage of the tendon or myotendinous junction. If that part is small, then it will give rise to different type of diseases. So here it is said that this coracoacromial arch, the word is important here. So you can see it is formed by the anterior portion of the acromion, means this area, anterior portion of the acromion, and this acromioclavicular joint. So this acromioclavicular joint and the coracoacromial ligament. So this is the coracoacromial ligament. So actually this whole area, this part is the coracoacromial arch. And why this part is important? Because the supraspinatus muscle and tendon, they are passing through this part. So this is the supraspinatus tendon. So think of some situation, if this head of humerus goes up, or for some reason this part comes down, and there is a narrowing of this space and between the coracoacromial arch and head of humerus, then there will be compression on this tendon. Okay, so this area is very important. Okay, some more part of anatomy. So there is different types of acromion. One is type 1, type 2, type 3, type 4. So how that is important? That is important to make the space between the so that is important for the space. Wait. So that is important for the space between the coracoacromial arch and the head of humerus. So you can understand, if this is the shape, so this is hooked shape. It can be flat, it can be curved, it can be hooked shape or reverse curved also. So if it is hooked shaped or curved shape, then what will happen? This space will become less, smaller, and those patients will be prone for supraspinatus tendon compression. Okay. Another important part is coracoid process. So coracoid process also has few parts. There is one is base part, this one is base, then ascending part, descending part, and tip part. So from here also which tendon is coming where we can understand. At the tip part only it is the short head of biceps, whereas in the descending part it will be the coracobrachialis. Greater tuberosity facet. So try to understand that how we are uh, seeing this structure. Again, this structure I took many months to understand this picture. So this is a sagittal view at the level of lesser trochanter. You are seeing from the side. This is anterior and this is posterior. Okay. So here we will be seeing the facets, three facets of the greater trochanter, from the greater trochanter. So this is the superior facet, this is the middle facet, this is the inferior facet. From one side we are seeing these three facets of greater tuberosity. This part and this part are not in the same plane. Okay, you can see in this picture. So this is the greater tuberosity, this is more lateral, and this is the head, this is more medial. Okay, that's why it is very difficult to understand. So why we want to know these facets? Because at different facets different muscles comes and joins. But in the say this facet supraspinatus, the its target is superior facet. Infraspinatus, its target is middle facet, but at some point both overlaps. So this is also important. Okay. Some vessels are important here. So one vessel, so we can see that ultimately shoulder is it is the supplies from the your axillary artery or subclavian artery branches. So these are the branches which supplies actually the area, mainly the shoulder joint. One artery. Somebody is asking any question? No. So one artery. So why we want to know these arteries? Because if we want know these arteries, then only we can see. And in those cases, we will not puncture the areas. Otherwise, doing some intervention, you puncture the artery, you will end up in some complication. So one artery is your, in some books it is arcuate artery, in some books it is circumflex artery, but anyway it is the circumflex artery or its branch, nothing else. So circumflex artery, so this artery is found in the bicipital groove. This artery is found in the bicipital groove. So remember about this artery, that we can find this artery in the groove. Now another artery is thoracoacromial artery. Thoracoacromial artery. So here there is anybody saying anything? Okay, thoracoacromial artery. So this artery, you can see that when we are seeing the coracoclavicular ligaments, then this thoracoacromial artery is seen. Okay, so this artery is also seen while locating the coracoclavicular ligament. If we do some intervention there, then this artery can be seen. Now comes nerve. Which is the important nerve? So that is the suprascapular nerve. We can see that from trunk area, suprascapular nerve is coming, and this suprascapular nerve ultimately comes through this supraspinatus fossa, and then it comes to the subglenoid, spinoglenoid fossa. Okay, so two different areas, same nerve only. So here you can see, and then it goes anteriorly like this. This is the brachial plexus, but branch comes like this. Okay, so today we will see only the suprascapular nerve in the supraspinatus fossa. But next day we will talk about the spinoglenoid area. Okay, so here's a small ligament is there, transverse scapular ligament. With very high frequency probe, we can see that ligament. Okay. Now we will demonstrate on volunteer. So first thing, before demonstration, I show you few things which we will see. So first thing is position and probe. Our selection of probe is linear probe. Okay, linear uh, broadband probe. Actually, in some areas we need high frequency, otherwise medium frequency is all right. Now different type of positions. Okay, so this is the neutral position. This is the neutral position for starting from the biceps tendon area, and this is the cross position. These are the modified cross position. Now when in a volunteer, volunteer can take these positions, which is cross position and modified cross position. But if it is not a volunteer and a patient, then it becomes very difficult to take all these positions. Then these type of positions where the elbow is flexed and shoulder is extended, this position is far better to see most of the areas of anterior shoulder. Somebody has written something. Okay, so these are the positions. Next is how we will arrange the things while examining. So I will stand behind the patient, and monitor will be there in front of me, in front of the patient. So I can do the ultrasound and see the monitor directly. So it should be in one line. Actually, during not only during examination, during the procedure also, patient should be in between the interventionist and the uh, monitor. Okay, patient may be looking towards you, or patient may be looking towards the monitor. That will depend how and where you want to give the do the intervention. But monitor should be straight in front of your eyes. Otherwise, neither you can examine nor you can do any procedure. Now demonstration purpose, identify the bony contours. There are some areas we can identify by palpation. So what are those areas? I can palpate the clavicle, and I can go to the clavicular end, and I can understand that which is clavicle and where is acromion. So acromial end we can palpate. I can palpate the spine of scapula. Okay, so these two things are very easily palpable. Now identify the layers. While we will in demonstration part, when we will see the muscles, we should identify the layers. Then only we will know that which muscle we are seeing. Then identify the tendon formation, myotendinous junction, up to tendon, myotendinous junction, and part of the muscle which is seen, we must see. And there is some critical areas. There is some critical areas for which is very notorious for tear. So that is 1 centimeter proximal to the tendinous insertion on the bone, because it is ischemia of, not ischemia, blood supply is always less there normally. So this part is very prone for any type of degenerative uh, degenerative tear. And myotendinous junction is more important when there is a history of trauma. So when we are seeing the tendon, we shall start from the bony insertion and go up to the myotendinous junction and part of the muscle which can be seen. Now identify the length and breadth of the structure. Remember, total length and breadth should be seen. Otherwise, if say one muscle, I mean, if you see only one part and another part, say anteriorly you are seeing and posteriorly there is a tear, you could not see. You thought that I saw the muscle in a long axis view, but then long axis view, not only anteriorly, it should go gradually posteriorly. Identify the, okay, look for the vessels. As I told you that during intervention, these are important. You should not inject in any vessel. Consider congenital variation. There can be some variation between uh, two person. So everything whichever doesn't match with a book picture should not be immediately, you should not say that this is a disease. That can be congenital variation. Identify the abnormality, compare with the opposite side. And dynamic examination, we must do dynamic examination during our uh, okay, we must do dynamic examination to rule out different types of impingements. Okay, to see that whether the movement which should be very smooth, that is smooth or not. This is the most positive point of ultrasound. Nothing, no other modality you can show a dynamic ultrasound. Dynamic movement you cannot do in any other modality. Okay. Another thing is expect a structure and understand the okay, expect a structure. Why I have said, because you should know the anatomy completely, then only you can see the structure there. Otherwise there will be too much confusion. We will adjust only the gain, depth, focus, frequency. Remember these four things: gain, depth, focus, frequency. In general, we need to adjust. In few machines now things are becoming automatic, but otherwise gain, depth, focus, frequency, just remember. No fixed protocol. Earlier we always used to start from the biceps tendon, but there is no fixed protocol. You can start from supraspinatus tendon also, and then infraspinatus, then like that. In your way, it should not be something very specific that in this way only I will go. Now comes, so this part I will start with demonstration. Okay, any question anyone has, please tell me. Otherwise I will show you with demonstration only. I will proceed, because otherwise it will take too much time.
Sir, what was the name of that position?
Crus position, CRUS, crus
Okay.
position. Okay, just a minute. Call the volunteer. Okay. So here, first let us see the bony contour. Okay. So I have selected a linear probe. So I will start from the humerus, lower end. Okay. So this is the bone of, this is the humerus bone, lower end. Okay. You can see the structure. I think there is no need for marking here. So this is the periosteum. This is the periosteum shadow, periosteal shadow of the humerus bone. Now gradually I will go up and I will see the, now actually you just focus to the bony shadow. You just focus to the bony shadow. So this is the, I go down. So this is the humerus bone, shaft of humerus. I'm going up, I'm going up, I'm going up, I'm going up. So in this area, gradually when I have gone up, okay. So here, can you see a groove between two? You can see that a groove between two hills. So what is that?
Bicipital groove.
Yes, this is the bicipital groove, and this is the greater tubercle, this is the lesser tubercle. Okay, here we are seeing at this area, this second one. Okay, this is second one. First one actually a bit more proximal when we are showing the shaft of humerus. So you can consider it as a second one. We are seeing the bicipital groove. Now I will show you the area where bicipital groove is not there, and just the inside the joint, it starting of the joint area. So this is the bicipital groove. Gradually, so here, this area, you can see there is no groove, no more groove here. So this area is the starting of the joint. Here groove is not there. So you can see the so this area is the groove is not there. This is the head of humerus. If it's okay, okay. We are seeing the head of humerus. Head of humerus. Okay, there is no groove. Now I will show you the sagittal section over the greater tuberosity. Then we will see the sagittal section over the groove. Then we will see the sagittal section over the lesser tuberosity. So three sections I will show one after another. কিরকম রাখতো হাতটা আবার ভুলে যাচ্ছি So let me show. So this is the greater tuberosity. I have brought it in the middle point. Here I will go with the rotation of the probe. So this is the greater, this is the greater tuberosity. Okay, shoot so this is the greater tuberosity. So this area is the greater tuberosity. Okay, you can see that I am marking this area. Okay, I am marking this area. Now I will see the bicipital groove area. So this is greater tuberosity. I am going a bit middle, in the middle portion. So this is the groove area. Please. Okay. So this is the bony periosteum in the groove. So my probe is here. I am seeing the groove area. Okay. Now I will go in the lesser tuberosity area. So just remember the shapes. Just by seeing the shape, you can actually say that which one is greater, which one is lesser. So this is greater tuberosity. This is the groove. This is the groove, Now I am going to the lesser tuberosity. Wait. So this is the lesser tuberosity. Okay. So please. Okay. So this is the lesser tuberosity. So one thing you have noticed or not, this is the lesser tuberosity. Here you see uh, greater tuberosity is a bit higher, lesser tuberosity is a bit lower. Okay, so here also if I come from lesser tuberosity to greater tuberosity, you will see the greater tuberosity appear here. Okay, because it is the cranial side, it is the cranial side, it is the caudal side. I think this is clear. Left side of your scene is cranial side. So you see, now I start from the lesser tuberosity. Right? Okay. Okay. So what is that? Oh. Okay. So this is the lesser tuberosity area. Okay. Now I am coming laterally. So this is the groove area. Now I am coming greater tuberosity. See, it has started more cranially. Okay, so this is the greater tuberosity, this is the groove area, and this is the lesser tuberosity. Okay, now let me see the.
Sir, can you repeat a groove area, please?
Oh, I will actually repeat after some time again because I have to show you the biceps tendon. This is the groove area.
So
This
I'm
is the
not
groove area.
understanding. Can you mark it, please?
Okay, please just a minute, Okay, shoot, not shoot. Acha. This is the bone of the groove, bony periosteum. This is the bony periosteum of the groove. Here, my probe is here. Okay.
Okay.
Now the fourth one is there. That is this one. That is this one. When already joint has crossed and it is over the glenoid. So this one was the your groove area. This one was the lesser tuberosity area. I am going more proximal. There is nothing, no joint. This is the wait. This is the glenoid area. Okay. Actually, this is the glenoid area. Okay. Actually, the joint. Here, just the joint space is going very fast. Anyway, so this area is the glenoid area. So here, so should watch please. So this is the this one. So this is the just glenoid over the glenoid bone. Okay. So this is most medial. So now let us see next slide. Okay. So I will start my scanning from the bicipital groove. Okay, so I am starting my scanning from the bicipital groove. Let me show you the same picture which is there at present on the screen. Okay. So this is the short axis of biceps tendon. Okay. Short axis of long head of biceps tendon. This is the tendon area. Okay. This is the lesser tuberosity. This is the greater tuberosity. This is the in between is the tendon. And here this side we are seeing only deltoid muscle. Only deltoid muscle. Here we are seeing the subscapularis muscle also, but that we will talk later. First, just understand short axis shows lesser trochanter, greater trochanter, bicipital groove, and here it is the short axis of biceps tendon. One important characteristics of biceps tendon is it shows great anisotropy. So now this is white, just I can make it black. Okay, white and black I can make it. So that is due to anisotropy and not due to any disease. Immediately you should not say that it is a biceps tendinosis. You can see the biceps tendon is black now. Okay, I bring it here, so now it is white. Okay, now it is white, but I can make it black, white, black. Okay, so this is called anisotropy, white, black. So here so you have to see by heel toe maneuver that or fanning. This is actually fanning. By fanning you should see that whether the tendon looks normal or not. Okay, so this is the biceps tendon in short axis. Now I will show you the biceps tendon in long axis. What's that? Just a minute. Okay, so this one. Okay, so already I showed the long axis in the groove area, bicipital groove area. Yes. So this is the complete tendon. This is the complete tendon. You can see the fibrillar pattern here. Okay, so if we go more proximally, we can see up to a limit, because ultimately this long head of biceps tendon is going to join in the going to become a intracapsular joining to the glenoid labrum. So we cannot see that much also inside the joint. But I will try to see a, so this much. Okay, now I can go, so you can see it is going. So here up to this much we can see, up to this much we can see. So after that we cannot see that where it joins, as this is the bicipital tendon. This is the bicipital tendon, biceps tendon, long head of biceps tendon. I think everyone can see, no? Biceps tendon. So what we see here, while we are seeing the biceps tendon, we will see a hyperechoic fibrillar pattern, and there should not be any fluid around. or yeah, there should not be any fluid around, though a small amount of say 0.2 ml 0.1 ml of fluid around the biceps tendon sometimes is considered normal. So we will see the long fibrillar structure hyperechoic. So that is the normal tendon. Okay. Now, as I am showing you the biceps tendon, short, long head, I have to show you the short head also. So where is the short head? So let us see, let us bring this picture. So what is this picture? This is about the, this is the, we will see the tendon of pectoralis major. So how we will see? From proximal side, we can still locate. So this is the biceps tendon, now white. As I am going down, this is black. Okay, this is hypoechoic tendon, round tendon you can see in the middle of the screen. Now I am going down, 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 and you can see at some point this tendon has become a muscle. So this is the muscle. Okay. So you see, now it has become tendon again. This is the tendon. Okay, this is the tendon. I am going here down, and it has become the long head. It is the long head of tendon. So if I go more medially, you can see, now see the structure in this in our PPT. This tendon is nothing but the pectoralis major tendon. This is the pectoralis major tendon. This is the long head of biceps. Then where is the short head of biceps? This is the short head of biceps. Okay, this is the short head of biceps, still muscle. This will form the short head of biceps, and this is the long head of biceps. Okay, below that, of course, that is the coracobrachialis muscle. So, and this part is nothing but the deltoid muscle. This upper part, it is nothing but the deltoid muscle. Okay, so you have seen. So this is the long head, this is the short head. How this long head becomes tendon? So here this long head has become tendon. Okay, you can see, so this has become tendon. This is the long head. Okay, and short head, as I told you. Okay, so this is the short head. Let us see that how this short head goes and joins with the coracoid process. Okay, we'll see it later also. Not now. Okay, we'll see later, because the depth I have to change, then I will see. But then I just showed you the short head and long head in the short axis view. Okay, so here it is there. So now see, I will show you the insertion of coracobrachialis. I will show you the short head of biceps, both the insertions. These are why these are important, because anywhere if there is a tendon, there is a chance of calcification, there is a chance of tendinosis or tear, though these are a bit rare things, that someone has coracobrachialis tendinosis or short head of biceps tendinosis, but still it is there. So depth ulta. Okay, so we will see that left side. So now what we are seeing, we are seeing head of humerus, and left side of the screen nothing but coracoid process. Left side of the screen is coracoid process. This one is the coracoid process, bony structure. Okay. So if from the coracoid I go down, straight away I go down. So the muscle which appears is nothing but coracobrachialis. So just I go up and straight away I go down. So this is the coracobrachialis. And this coracobrachialis you can see in a long axis manner like that. So you can see this is the coracobrachialis, how it joins and comes. Please, okay. So you can see the coracobrachialis, how it joins in the coracoid process. So this is the coracoid process. This is coracoid process. This is the coracobrachialis muscle. This is very short tendon. It has very short tendon. So this is the coracobrachialis. Okay. Now I will show you the short head of biceps. Now I will show you the short head of biceps. So again, I show you the coracoid process first. So this is coracoid process. From here, I am going to show you. So this is the short head of biceps. But how can you understand that this is the short head of biceps? Okay, first I will. Okay, please. So this is the short head of biceps tendon, short head of biceps tendon. From here the muscle starts, here the muscle starts. And this is the coracoid process. This is the short head of biceps. I will go a bit distally and I will show you in short axis that this is the short head of biceps. So again you see, so this is the short head of biceps, biceps. I'm going distally, and now I will make it as a, so this one you can see the biceps tendon has started. The upper part, middle part, this is the biceps tendon. So this is the biceps tendon which is started, short head of biceps. This is long head, this is short head. Okay, so short head I can come like this, and you can see that this is the short head of biceps which is going and joining in the coracoid process. This is the tip of the coracoid process. Okay, tip of the coracoid process, and it is the short head of biceps. Okay, so these two is okay. Pectoralis minor is not needed. Hardly we can find anyone.
Can we see both the muscles in a single view? Short head of
No.
biceps, coracobrachialis.
No, you cannot see in a single view because they are not aligned over each other. They are coming. One is short head of biceps. Biceps is a bit lateral, and because it is going in the short head of biceps is a bit lateral, and coracobrachialis is a bit medial. So you cannot see in a single view. You have to tilt.
So then how to differentiate? Will we not confuse between the two muscles?
Uh, but two are different. I mean, short head of biceps, I told you that this white color tendon, and that's why, I mean, whenever you feel that whether it is the real muscle or not, then go distally and see the muscle. So I showed you, no, here I'm just again showing you. So this is the short head of biceps. Okay, so this is the short head of biceps. So it has to become the biceps. Then only you can say that okay, it is the short head of biceps. So it has become the biceps. It has become the biceps, isn't it? The upper one, it has become the biceps. Then only you can understand that this is short head of biceps. And when it is coracobrachialis, then I told you that from the coracoid process, this is the coracoid process, and this has become the muscle. Okay, now you make it a tendon again. Now you can see the muscle. So you can understand these two are completely different muscle, completely different. You can go down, but this is the muscle, this is the muscle, this is the muscle. Okay, so now it is the below one, down one. Okay, and it is completely different. This big muscle.
Okay.
Here tendon is much smaller. This only the upper part is the tendon. Okay, only small part is the tendon. And so this is the at the joining when it is going inserted, then you can come a bit laterally and you can see. So this is one tendon, and just laterally you come, you will see the short head of biceps tendon here in the medially, here in the laterally. Okay. Confusion will be there, but then uh, gradually after seeing you will find the difference, that one is very hyperechoic, short head of biceps, the hyperechoic tendon you can see. It is a, in picture also we can see no long tendon, but in coracobrachialis it is not so.
Okay, sir.
Okay, now we will show you the subscapularis. So from the front side, as we started from the biceps area, and we will started from the biceps area, and now I am showing the subscapularis area first. Then we will go to the supraspinatus. So, should freezer. Acha. So here, as soon as I find the bicipital groove. Oh, here, okay, let that I will show. So here, see, one more important thing. We know that subscapularis is coming from this side. This side it is coming and joining in the lesser tuberosity. So just above the scapula, it is coming from this side, like this side, but in this area anteriorly and coming to the lesser tuberosity. So and it is under the coracoid process. Here there is a coracoid process. It is actually covering the part of the subscapularis. So what can I do to see more of the subscapularis tendon? So then we have to do the external rotation of the hand, external rotation. This is internal rotation, this is external rotation. So if you do external rotation, what will happen? The lesser tubercle will move from this side to this side. It will come this side. So the attachment in the lesser tubercle, you will see a bit lot of tendon here. So that is why I have kept the volunteer's hand in this way. Okay. So now, so here we are seeing bicipital groove. We can understand that which one is the lesser tubercle. So this one is the lesser tubercle. So let us see the tendon of subscapularis. So here we are seeing the tendon of subscapularis. Here one important thing is there. Just please go. আর ঘুমা সারাটা দিন। Okay. So we have already understood that this was the bicipital groove and biceps tendon is here, and this is the lesser tubercle. So where is the subscapularis? So this is the subscapularis tendon. This is the subscapularis tendon. But now here one more important thing is there, that is this part is nothing but myotendinous junction. Why? We can see some black area and some white area, again some black area. So this is the myotendinous junction. Since the hand is in the externally rotated position, so this has come out from below the, here is the coracoid process. So it was there under the coracoid process, but it has come out now. So up to the myotendinous junction and a part of muscle also you can actually see in this picture. Another important thing, total tendon you cannot see together as a hyperechoic structure. When this part will be more hyperechoic, this part will become hypoechoic, and the vice versa. Okay, so heel toe maneuver is needed to see this tendon. Okay, heel toe maneuver. So I show you how. So okay, here you can see we are seeing more or less the, so this medial part of the tendon is now more hyperechoic than the lateral part or the insertion point. If I want to see the only insertion point, then I will do this type of movement and heel toe maneuver, this type of heel toe maneuver, and I can see the one end of the insertion end of the subscapular is hyperechoic, but other area has become, the left side has become the hypoechoic or black. So I am doing this heel toe maneuver and I can see this part also becomes hyperechoic. If I go more medially, then I can see clearly that myotendinous junction is there. Black white structure we can see in the left side, and as we can see that just above in the left side coracoid bone is coming, coracoid process bone is coming. Okay, so I show you here the dynamic movement by which we have seen the a long amount, a more part of the tendon. Now you can see if patient's hand would have been like this, then you will see a much less amount of tendon here, but patient's hand is like this, then only you can see a lot of part of tendon. Okay, more part of tendon. Okay, একটু ভিতর দিকে নে তো হাতটা, আরো নেই আবার ঘোরা পুরোটা না পুরোটা, আরে এটা যাক না, এটা কি এরকম কর, হ্যাঁ okay. So you can see with this movement, so what you see, that how much tendon you will see, that will depend that in which area in you are seeing the tendon in which position. Here one more important thing, since we are seeing this part now, so we will see the dynamic movement of the subscapularis tendon under the coracoid process. Move কর। So this dynamic movement is also very important. How? পুরোটা ঘোরাচ্ছিস না, ফুল কমপ্লিট মুভমেন্ট, হ্যাঁ কর তো পুরোটা, হ্যাঁ এদিকে পুরোটা ফুল, হ্যাঁ এবার ফ্রিজ কর। Okay, so this is the complete internal rotation. So complete internal rotation by which what we can see the biceps tendon is here. Okay, this is the greater tuberosity and this is the lesser tuberosity, but we cannot see much, and this side is nothing but the coracoid process. So this is the bony area of coracoid process. So here this area, in this area, the movement of in this area, the movement of subscapularis tendon and lesser tuberosity and biceps tendon, this has to be smooth. If there is an impingement, then we shall call it as a subcoracoid impingement. Okay, different areas impingement can occur. So this is another site of impingement. Okay, impingement means patient feels pain when patient is doing a certain movement, that is called impingement syndrome. Okay, okay. So this part you have understood, I think, no? There is no confusion. Everyone has seen the subscapularis tendon. Now this subscapularis tendon we will see in a short axis view also. As already I showed you that myotendinous junction black white. So how that we will see in a short axis view. So you can see. So this is the your subscapularis tendon, and already this part left side, middle side, this is the black white part. তো একটু ঘোরা তো ওইদিকে। So this area, okay, this area black white এরকম রাখ। So this area black white area is there. So if I make it a short axis view, then what we will see? So this is the, I will make it a bit deeper. Okay, so now you can see the picture. You can see this is the short axis view of subscapularis. Here also black white is there, black white is there. So this is the short axis picture of subscapularis. So when starting from here, we will again come up to the lesser tuberosity where it joins. Okay. Left side is cranial side. Okay, left side is cranial side. So we can see, so okay, this is the black white picture of your subscapularis tendon, and this is coming in the lesser tuberosity, and it has already joined here. So if there is no problem, you will not be able to see. So otherwise it has already joined here. So this is the area where the subscapularis tendon has already joined. Okay. Okay. So next, let us go to the most important tendon, that is the supraspinatus tendon. So here also supraspinatus tendon we will see in a short axis and long axis view. Hey, what is happening? Oh, share screen. Okay, so next is the supraspinatus tendon. So we will see in a short axis and long axis view. So remember, in supraspinatus, our position, we don't require this, and nowadays the position in this type of position is enough. Okay, okay. So this type of position is enough. So we have already understood that clavicle, we can palpate the clavicle. So between the clavicle and spinous process of scapula, between that, all the structure what we are seeing, all the muscles what we are seeing, that is either trapezius or supraspinatus. So in this area, either we will find trapezius or supraspinatus, I mean both muscle, trapezius superficially and below that supraspinatus, between this clavicle and spinous process of scapula. So let us see. So see two layers of muscle, can you see or not? So here, this is one layer of muscle, and from this to this is another layer of muscle. You can see that this is a bit more black than this part. This is a bit less hypoechoic, this is more hypoechoic. Okay, and someone can say that here there is another line, white line, this one. So why not this is second muscle, this is third muscle? No, because this is the central tendon of supraspinatus. This tendon is being formed from here only, from the muscle bulk, and gradually the muscle will become smaller and tendon will become bigger. Okay, so this total part is supraspinatus, and this is upper part, this is the trapezius. Okay, now let us see. So here what I can expect. So here what I can expect. So two muscles you have seen, two muscles you have understood that two muscles are there. Now here in one bone is coming here. So we can palpate one bone also. So what is that bone? That bone has to be the acromion. That is, bone has to be the acromion. So when I'm, as I already showed you, that ultimately supraspinous tendon is going between a space of acromion and humeral head. So now I have to search the acromion, and between acromion and humeral head, supraspinatus tendon will go and join here in the greater tuberosity. Greater tuberosity is here, already we know. Lesser tuberosity was here. Okay. So let us see if we can see the muscle and central tendon. So this central tendon is going below the acromion, below the acromion, and gradually this part it has become complete tendon. This part it has become complete tendon, and we can see it has come and joined at the greater tuberosity. Okay. Acromion. This is called bird beak appearance. Bird beak appearance of supraspinatus. Okay. This is the, actually this area is greater tuberosity. This is the neck, and this is the starting of humeral head. It will be like this, but we cannot see, but this is the starting of humeral head. Here sometimes a part of cartilage is also seen. If we do more, if he does cross position, then we will see a bit of cartilage here. But then this is the supraspinatus tendon and bird beak appearance, which is inserting at the greater tubercle. So I think this one everybody has seen, understood. And one important thing is supraspinatus tendon, as here it was too deep, no, too deep, but here it is much superficial. I can decrease the depth a bit to go. Okay, okay. So the depth is decreased. Here it is the bird beak appearance. I am showing you the short axis also. So let's.
So the volunteer and probe is not visible.
Oh, just a minute. ক্যামেরাটা আটকে গেল কি করে? হুম। 1 minute was just 19. Just a minute. Just a minute. Failed. Got it. আচ্ছা। Unique 5G. আমি তো ক্লোজ করেছি। উপরের থেকে দেখি এটা ঠিক জায়গায় লাগানো আছে কিনা। 5G তে আসছে তো। 5G অনেক আগেই এসছে। দেখি তুই ইয়ে করিস না, না না ওইটা না তোর, vertical client. Okay, just wait. Or just 2 minutes. I will make it all right. Okay. Sorry, because lack of things happen. So anyway, uh, you can see the screen, isn't it?
Yes, visible, visible.
Okay. So supraspinatus tendon, I have shown you the short axis and long axis both. Hmm. Hmm. Okay. Okay, short axis I did not show maybe. Okay. Hmm. Okay. So this one was supraspinatus. Okay, this one was supraspinatus. If I go for short axis, it will be like this. It will be like this. So it is coming and joining here. It is like this. So here sometimes it becomes a bit difficult to understand that which side is supraspinatus, which one is supraspinatus. So I will show you later that how we can understand which one is supraspinatus. Okay, here the main point is we will target again the bicipital groove. We will target the bicipital groove. So I will show you the picture, then you will understand. So ultimately, this is the short axis of supraspinatus. This is the short axis of supraspinatus tendon. Okay. You can see this is the supraspinatus tendon, and it is ultimately coming and joining here. So it is joined already. Okay. This part is the supraspinatus tendon. So this is the tendon and this is joint. This is the tendon, so this is the tendon and this is the tendon and this is joint. Okay, but then in this way only, in longitudinal view only, you can see the supraspinatus in a better way. SASD bursa. So this is the most important during our all procedures. Where is the bursa? So the same position when I am seeing the supraspinatus again. So here let us see let us decrease the depth to understand this bursa better. Okay, so here please. This is acromion, we all know. This is supraspinatus tendon, we all know. This is greater tuberosity, we all know. So now this is deltoid. Okay, so two muscle layer we can see. Here I will show you again a small amount of cartilage you may be able to see. Now between these two muscle, one muscle and two muscle, so this is the area for bursa. We know that it is above the supraspinatus. So can you see this black line, within this white structure, within this white loose areolar tissue, you can see this black line. So remember, this black line is nothing but the bursa. So I show you again that how we can see the bursa in a nice way. So whenever there is no fluid, you cannot see bursa better than this. So this is the bursa. Okay. So black line within the white line. Black line, black line within the white line. This is the bursa. This is supraspinatus. This is supraspinatus. This is upper one is deltoid and this is acromion. Okay. So whenever we want to see whether there is bursitis or not, we will see fluid here, fluid here. Okay. So in this area, if I make a short axis of this, then also you can understand that which one is bursa and which one is not. So this is a short axis of supraspinatus and this one is the bursa. So in short axis also you can see supraspinatus and bursa here. Okay, this black line will be more inflated. Okay. You can all see, no, clearly.
Yes, sir.
Okay. So next is ligaments. Next is ligaments. So just see that these are the three ligaments. Already I have told: coracohumeral ligament, coracoacromial ligament, and some coracoclavicular ligaments. Glenohumeral ligaments are also there, but glenohumeral ligaments, it is much deeper and smaller. We will show. First, so you remember this picture. So let us see first coracohumeral ligament and glenohumeral ligaments. Okay. So this is the, okay. First, let us see the coracoacromial ligament because that is much easier to see. Coracoacromial ligament. Okay. So our volunteer can sit in a neutral position. I'm recording or not? Okay, I'm recording. Okay. So coracoacromial. So already you understood that bicipital groove was there. So this is the bicipital groove, and when we went medially, we saw the coracoid process. If I am a bit below, then it is the coracobrachialis muscle. This is the coracobrachialis muscle. When I go up, this is the coracoid. Now there should be one tendon from coracoid to acromion. Then only I can say that this is a coracoacromial ligament. So what I need to do, one side will remain fixed in the coracoid and another side will be moved towards the acromion. Then, so this is the acromion and one side is in the coracoid. So this is the coracoacromial ligament. Let's see more nicely. So it starts from the coracoid and move one side to the acromion. So this is the, you can see a fibrillar structure. This is the fibrillar structure. So this is the fibrillar structure. So this fibrillar structure is nothing but the coracoacromial ligament. Okay. So this is the fibrillar structure. So freeze. Okay. So coracoid, this side acromion, and this is the fibrillar structure. What is happening? See. Okay. So this is the coracoacromial ligament. This is the coracoacromial ligament. Okay. So now we will show the next ligament, that is coracohumeral ligament. So before seeing the coracohumeral ligament, you see how it looks. So you can see that it's causing problem. This is the humeral head. So just from the glenoid cavity, it has been removed. So you can see from humerus to coracoid. Okay, from okay, this is glenoid actually, glenohumeral ligament. Just a minute. Okay, this is glenohumeral ligament. So this is glenohumeral ligament, and next one is so this one is coracohumeral ligament, but as I already showed you, so this one, okay, we will see the both glenohumeral and coracohumeral ligament. Okay, so you have understood that from coracoid to humerus, both lesser tuberosity, greater tuberosity, this side is lesser and this side is greater. So greater tuberosity, we will see the coracohumeral ligament, and bicipital tendon is it is going through the bicipital groove. So both side of the biceps tendon, we will see the coracohumeral ligament. Okay, and now where we will look for the glenohumeral ligament. So in this picture, you can see that glenohumeral ligament we can see, where we will see. So this blue color, this blue color is nothing but the coracohumeral ligament, upper one above the bicipital tendon. But below that, this small area is there, one small curvy black line is there. So this is the area for glenohumeral ligament. Okay, so below the tendon, so this is the area for glenohumeral ligament. Above the tendon, this will be the coracohumeral ligament. Okay, so I will show you now. So now again we will see the bicipital groove area very nicely. Okay, so again we are seeing the bicipital groove area very nicely, but now I am seeing it a bit more with a bit more high frequency I am using, and I am seeing it by zooming. So actually for seeing these ligaments, you need a very high frequency probe machine or high frequency probe. Okay, but then that we will show in the next day. We can show more in a better way by the high frequency machine. This picture is causing, just a minute, I'm changing this one also. This picture is causing too much issues. So the area where I shall find. So here is the biceps tendon. So this is the subscapular side. This is the medial side. This is the medial side, and this is the lateral side. Here, if the coracohumeral ligament I have to find, then it should come from medial side to lesser tubercle, medial side to lateral side. So what will happen? I will see a tendon like this and coming above this, or and like this. So there should be two insertions. One is in this side and one is in this side. Okay. So that will be the coracohumeral ligament. And since it is above the coracoid process, so it is a bit coming from the from superior side. I mean, like it is not at the bony level. Glenohumeral level is at the bony level. We can see it here. Okay, but coracohumeral ligament will be a bit superior. I mean, it is not that deep. This subscapularis will be below.
Sir, you're not audible, sir.
Now you can see, you can hear.
Sir.
Hello.
Yes, sir.
Oh,
Yes.
okay. So what I am saying that this is biceps tendon, and these part should be the insertion of coracohumeral ligament. Okay, it is not at the bony level, just above the bone. It is not that. It is a bit more superficial here, under the coracohumeral ligament, though it is not directly under, but depth wise below that, that is the subscapularis muscle. Okay, so from here it will come, and we will see the tendon here, one insertion here, one insertion here. So that is coracohumeral ligament, and you can see this small, here you can see one curved line, black curved line here. So that is the area of glenohumeral ligament. So where we will see here the glenohumeral ligament will be below. So let's see if we can, you can see that what is coming from medial side, it is something is coming and joining here. So here, this is joining here. Okay, so biceps tendon is what is becoming black and white, but above biceps tendon there is something. Okay, there, this one, upper one actually. So this one, above biceps tendon, this one. So this one is coracohumeral ligament. From this side, it is a bit difficult to see, but coracohumeral ligament comes and joins in this side also. From otherwise it joins here also. So this one is the coracohumeral ligament, and below this area we will be able to see the glenohumeral ligaments. This part I will show you next day also by a very high frequency probe. So just see this much only here. So now you can see clearly this is the coracohumeral ligament. So this is the coracohumeral ligament. Okay, this is the coracohumeral ligament. And this coracohumeral ligament we can see from coracoid process also. How? So this is the coracohumeral ligament. This is the starting of coracohumeral ligament. From here, this is the coracoid process, and it is gradually going towards the humeral side. If I make it a bit stretched, then you can see the coracohumeral ligament clearly. So two areas we can see coracohumeral ligament. One is in this area where we do measurement for frozen shoulder. Coracohumeral ligament thickening is one corroborative evidence of frozen shoulder. So this is coracohumeral ligament one side, and another side is here in this area. So you can see, so actually this one is coming and joining here. but this side we cannot see, but this side also coming and joining here. So this side, this is the coracohumeral ligament. This is the coracohumeral ligament. Okay. So glenohumeral ligament, next day we will show by a very high frequency probe. So that is actually these are glenohumeral ligaments. These are glenohumeral ligaments. Okay, these are the at the bone, just above the bone here. These are glenohumeral ligaments, and here also some glenohumeral ligaments can be seen. Mainly this one we can see. This is the glenohumeral ligament. Okay. Okay. Actually, we are going very slow. We have to be a bit fast. Now, very important part is your this one, your rotator cuff interval. So already which I showed you. So you can see that coracohumeral ligament from above, which has come above the suprascapularis, and this is the subscapularis. So coracohumeral ligament comes here also, and actually this is the glenohumeral ligament just below. So coracoid rotator cuff interval, what is it? So you can see this picture. So once this long head of biceps, it is going and entering in the glenoid labrum. And since we are calling it as a cuff, okay, cuff, because it is totally, all these four muscles are actually covering the glenohumeral joint, but there is a gap. This is the subscapularis which is covering the joint. This is supraspinatus is covering the joint, but there is a gap.
Sir, where are you showing?
Oh. Okay, my movement of EA is not there, no? Anyway, okay. So you can see that this is the glenohumeral ligament, and just at the just above the bone. Okay, and this is the coracohumeral ligament. It is coming from the subscapularis side. Now, what is rotator cuff interval? So rotator cuff interval is this area where the long head of biceps tendon is going and joining in the glenoidal labrum. In one side, anteriorly it is subscapularis, upper side superiorly it is the supraspinatus. In between this area is there is a gap, and it is not covering the glenohumeral joint. That's why it is called the rotator cuff interval. All the other areas are covered by rotator cuff, but this is the interval. So you can see from the side also that in between area, this area, there is some ligament and all, but main muscles are not there. So this is called rotator cuff interval. How this part is important to us? Because you can see that capsule, I showed you that time, that joint capsule comes a bit distally, just around the long head of biceps. So if you want to inject something inside the joint, you can inject just around the biceps tendon. That's why this rotator cuff interval is important. Okay. So remember, so this picture only, if I show you in a short axis manner, I cut it in a, say, in this way. If I cut, okay, then what you will see? Then you will see this picture. Okay, just a minute. Then we will see this picture, that one side supraspinatus, the superior side, and anterior side subscapularis, and in between the biceps tendon. So to see the rotator cuff interval, we will be seeing this area. Both the muscles we will see, and biceps tendon we will see. So rotator cuff interval is very important for doing any procedure. Okay. So how rotator cuff interval? So this is the, you can see the, again the bicipital groove. We can see that biceps tendon is a bit tilted towards the subscapularis. Okay, it is tilted towards the subscapularis. Medial side means left side of your screen. We can see the subscapularis tendon. Okay, subscapularis tendon, and biceps tendon you can see in the middle side. Now, when I want to see the rotator cuff interval, then first I need to come at the most upper part from where the tendon is tilted and going just about to go in the intra-articular position. Okay. Then I will tilt one end to the acromial side, okay, towards the acromial. Then what I am seeing actually, now try to understand the picture. Right side you are seeing the supraspinatus in a short axis view, and left side you are seeing the subscapularis muscle. Okay, left side it is the subscapularis muscle, and right side it is the supraspinatus muscle. Okay, so here in between it is the biceps tendon, in between it is the biceps tendon. So if we inject anything in this here, in this position, just by the side of the biceps tendon in this area, just by the side of the biceps tendon in this area, if we see anything, then the fluid must go inside the joint. Okay, so this is called rotator cuff interval. This, in rotator cuff interval, you must see both the muscles in short axis view. Of course, this muscle will not be in the short axis view, this is in the long axis view. So annotate. So this one is biceps tendon, already you understood, this is biceps tendon, this is subscapularis, this subscapularis in a long axis view. Okay, this is in a short axis view, supraspinatus, short axis or cross sectional view, at least not exactly short axis, but it is cross sectional view. So this is the area which I am telling you, this one between the supraspinatus and subscapularis. Okay, so you inject anything here, your injection, if it comes from this side and comes here, the fluid immediately goes inside the joint capsule. Okay, so this is one important thing. Rotator cable. So rotator cable, if you want to understand, okay, so you see rotator cable. What is this rotator cable? Means this picture is good enough. So here as I told you, this is so as I told you, this is medial side and subscapularis, this is lateral side and supraspinatus. Okay, but what keeps the supraspinatus and subscapularis on the bone? So there is one structure which is called rotator cable. Rotator cable is also a ligament type of structure that keeps the whole tendon on the bone. So you can see that rotator cable comes from this cable bridge. You can compare it with a cable bridge. So from one side to another side, cables are going, but there are some cables which are going perpendicularly, so that this tendon remains straight. So here also there is one rotator cable which forces towards the bone, which brings the tendons towards the bone. So where I will see this rotator cable, a different type of structure, fibrous structure, tendinous structure, we can see just below the supraspinatus muscle. So supraspinatus muscle or tendon area. So that is the rotator cable. Just let me show you. So I think you have already, so the left side biceps tendon you can see, and here, please. Okay. So already this side was biceps tendon, this side supraspinatus you understood, but here there is another type of fiber. Okay, it is a tendinous fiber. So this fiber is nothing but rotator cable. So this fiber is this fiber. Okay, just below the supraspinatus tendon. So here also I am seeing this is supraspinatus tendon, but below here there is some fiber. This is called rotator cable. Okay. None. Coracoclavicular ligaments are not that important, but for the sake of completing, I will just show you the coracoclavicular ligament. So here first I will I'm just slow. This is the coracoid process. I bring it in the middle part and then I just rotate it. I just rotate it and I see in the right side it is the coracoid, and it is the in the left side it is the clavicle. Left side it is the clavicle. So try to see the picture here. Just a minute. In the PPT, just try to see the picture. So here you can see this is coracoacromial ligament. This is the coracoacromial ligament, but here there is a pulsatile vessel also. I showed you the pulsatile vessel. So this is coracoacromial ligament, and this pulsatile vessel is nothing but coracoacromial arteries. We just see again this artery. If you have not noticed, just see. So this is the coracoacromial vessel. You can see pulsatile vessel. Yeah, you can see pulsatile vessel. So just behind the below the vessel, this is the coracoacromial ligament. Now, so just below the vessel, this is the coracoacromial ligament. Okay, so this is not that important anyway. Okay, another. Okay, so this thing I just show you the. I just tell you in a theoretical thing. So this is C, transverse humeral ligament. What is transverse humeral ligament? So this is, you can see that coracohumeral ligament ends at the most upper part. Okay, all these ligaments. But after that also in the bicipital groove, this long head of biceps is still there. So what is holding them on in the groove? Why it doesn't come out? So that is the transverse humeral ligament works. So this is nothing but this is the location of coracohumeral ligament only, but it is below that. So that is the transverse humeral ligament. So this I will show next day with the biceps pulley and sling. This is not at all very important. Uh, Here one more important thing is biceps pulley or sling. It is not a single structure. This is a capsuloligamentous complex which is stabilizes the long head of biceps tendon within the bicipital groove. So it actually contains coracohumeral ligament, superior glenohumeral ligament, distal attachment of subscapularis tendon. So all those things together, and it brings so together it is called that biceps pulley. So ultimately it keeps the biceps tendon inside the bicipital groove. Glenoid labrum actually always diagnosed by MRI. We cannot see by ultrasound, but of course in some areas procedure has been done after diagnosing by MRI. Some procedure has been done. There are some some is there, some report is there. Acromioclavicular joint, I will show you the acromioclavicular joint, acromioclavicular ligament. These things are supraclavicular nerve also I will show you. But that's it. So share screen. So acromioclavicular joint and suprascapular nerve. These two things are pending. So this is the acromioclavicular joint. Simply, basically, I can palpate the clavicle. I can palpate the clavicle, and as soon as I come here, I see the acromioclavicular joint here. So this is the acromioclavicular joint, and joint capsule is there. The upper part, it is the joint capsule. This one is the joint capsule. This one is the joint capsule. This side it is the acromion. Medial side, left side is the clavicle. Left side clavicle, right side acromion. And this is the joint, and this is the capsule. So how will you understand that which one is acromion and which one is clavicle? So as soon as I go in the right side, I can see that below acromion it is the supraspinatus tendon. Okay. So this is acromioclavicular joint. Now another thing, last thing is your, I think you have understood, no? Everyone has seen acromioclavicular joint? Clearly seen, no?
Yes.
Yes, sir.
Okay. So now last thing you see, that is the supraspinatus, suprascapular nerve in the supraspinatus fossa. So I will increase the depth a bit. I will increase the depth a bit. So now two muscles we can see. So it is my how I put the probe. Okay. So if I put the probe and which is directed a bit backward, then I will see only the bone of the scapula, suprascapular fossa, all the bones. But if I make it a bit like this, okay, then what I will see? I will see some vessels and a gap. Okay, so these gap and these vessels are nothing but the suprascapular artery. Now it is very hardly we can see the, so this artery we can see. Here, let's see artery we can, so artery we can see whether it takes color or not. So you can see this is the artery. So this is the supraspinatus fossa for suprascapular nerve. Okay. So this is the artery. This is the suprascapular artery, and just by the suprascapular artery, it may be the suprascapular nerve. So we cannot say by guarantee that this is the nerve, but when we do intervention, we come at this depth, and just by the side of the artery we will inject. So at this point we will inject. We can come from inline approach also, or we come out of the plane approach also. Both are okay. So here actually there is one transverse scapular ligament. So if the patient is thinner, then only you can see, and injection should be done below also, above also. Okay, then the transverse scapular ligament, because this nerve sometimes below and sometimes above the transverse scapular ligament. Okay, so I think actually full pathology is pending. Should I continue? I don't have a problem, but 2 hours is over. So are you fatigued, or I should continue? Otherwise, we can take it next day also. So what is your wish? Tell me.
The next time.
I think next day. This is too much for today.
Okay. Next day we will start with the pathology first, and then we'll start demonstration of the posterior side. Okay, but whatever I have said today, I have many videos, so I will post it in group also. So the thing is that whatever I have said, this is what showed today. This is about the concept. Okay, you should develop a concept that from which side muscle is coming, where you should find what. Otherwise, it is not about the memorizing the picture. It is about the concept. that anatomical under the skin, where can be the muscle be, that should be in your mind. It takes a lot of time actually. So it's okay. Next day we will meet, and we will go with the rest of the part of the shoulder. Okay, thank you then.
Thank you, sir.
Thank you, sir.
Okay.